Welcome everyone, and thank you for joining us. My name is Dr. Famida Jiwa. I'm the President and CEO of Osteoporosis Canada, and I'm very pleased to be your moderator today. Each Bone Matters Take Charge of Your Bone Health presentation is led by a Canadian expert in osteoporosis to help participants understand how to prevent the next fracture and how to live well with osteoporosis. Today, we are delighted to welcome our guest speaker, Dr. Marla Shapiro. In this presentation, Dr. Shapiro will share with you her personal journey with osteoporosis. She will also discuss the importance of knowing what a fracture can mean to you. To submit a question, on the side panel on the right-hand side of your screen, you will see a box that says questions. Type in your question in the text box, and we will receive your question to answer at the end of the presentation. You may submit a question at any time during the presentation, and it will be addressed during the question and answer period. If time permits, if not, we will answer them after the presentation. So please be sure to include your email address in the body of your question. Otherwise, we will be unable to send you the answer. Dr. Marla Shapiro is a well-loved and highly acclaimed family physician, health journalist for CTV, and author. Also, she is a professor at the University of Toronto. In 2015, Dr. Shapiro was named a member of the Order of Canada for her contributions as a family physician and a trusted source of health information. She has been named one of the top 25 most powerful women by women of Influence magazine in Canada. She is the recipient of many other awards and honors. We are very pleased to welcome you, Dr. Shapiro.
Thanks, everybody. So we're going to talk about the patient journey, and we're going to go through some data and information that hopefully can empower you to understand how you can deal with your own journey. Okay. Just some technical issues as we work out why I can't advance my slides. Okay, there we go. Okay, so the first is a global call to action. What we really want to do is address the osteoporosis crisis, and organizations across the world have identified the following calls to action. Firstly, making sure that our healthcare providers have education that's focused on diagnosing and treating patients at high risk for fracture. Often when we see our own physicians, there's so much on the agenda that bones often get omitted and don't become a priority. To be able to engage health organizations to increase support for high-risk patients, and to educate insurers about effective services to improve diagnosis and treatment of these high-risk patients, and to identify strategies for health systems to adapt and use quality measures to screen and treat high-risk individuals. We don't want our high-risk individuals falling through the crack and not being really diagnosed. But the question is for you as a patient, as a consumer, what is your role? So let's first look at the scope of the problem. Each year in Canada, there are about 30,000 hip fractures, and there are many more Canadians that suffer osteoporotic fractures that affect multiple sites. Those include the spine, the wrist, the shoulder, and the pelvis. 25%, that's the risk of suffering a second spine fracture within the year following the first one. And bear in mind that many of these spine fractures are completely without symptoms. You may note that you're getting a little bit shorter, but you may not necessarily have pain. So 2/3 of these fractures do not present with pain, but having that fracture puts you at a 1 in 5 risk to have another fracture within the spine within that year. This is a marker of what we call morbidity, meaning illness, and it also increases your risk of death or mortality. The start one statistic is that 1 in 3 fracture patients will re-fracture at 1 year, and over 1 in 2 will suffer another fracture within 5 years. So in other words, that first fracture is a sentinel event. It's a call to action that often gets ignored. Several effective medications can reduce fracture risk by somewhere between 30 to 70%. So it's truly important that we identify these high-risk individuals. Over 80% of all fractures in Canada after age 50 are caused by osteoporosis, and 80% of fracture patients are never offered screening and or treatment post-fracture. So imagine if you've had a cardiovascular event and you're in the hospital, you're not going to leave without medication, treatment, and follow-up But in fact, that's exactly what happens to many fracture patients who present through an emergency room. As many as 1 in 4 patients who have a hip fracture will require admission to a nursing home. And fractures from osteoporosis are actually more common than heart attack, stroke, and breast cancer combined. When I ask my patients what they value most is independent living. And a fracture can change your ability to do that. 1 in 3 women will suffer from an osteoporotic fracture during their lifetime. And let's not forget men. 1 in 5 men will fracture during their lifetime as well. And many of these fractures can be prevented. So let's look at women. Look at the number of osteoporotic fractures that we see, 153,000 or greater. In the same period of time, we see about 50,000 or less heart attacks, slightly less than 30,000 strokes, and about 22,000 or so cases of breast cancer on an annual basis. And if you add up heart attack, stroke, and breast cancer, in fact, those numbers are less than the prevalence of fractures in Canadian women, be their vertebrae, their spine, their wrist, their hip, their pelvis, or other sites. But somehow we don't pay as much attention to this as we do to the other 3. So it raises a question. Why do 80% of those patients that I mentioned to you, having had a cardiac event, leave with a loot bag that includes medication? And it doesn't matter where you are across this country, you're likely going to leave with the same type of medications, be it Montreal, Toronto, Winnipeg, or Vancouver. We all pretty much treat to target in terms of blood pressure, cholesterol, and reducing the risk of another cardiac event. Yet only 15% of patients who present with a fracture who need osteoporosis treatment actually leave with some type of treatment post-fracture. So how do we shift this paradigm so that 80% of our osteoporotic patients are actually getting treated? Why are they being missed? Remember that a fracture is to osteoporosis what a heart attack is to a cardiovascular disease. You would not ignore a heart attack. Why are we ignoring fractures or thinking that a fracture is a commonplace event that happens as we get older? So let's look at the difference between osteoporotic fracture rates and the numbers. There's much more to the study. So what you're looking at is what we call a bone mineral density distribution. Anything above 1 is considered normal. As we start getting minus bone densities, -5 to -1, -1.5 to -2, -2.5 is what we call osteoporosis. The more osteoporotic you look on a bone density, the more likelihood you are in terms of that bone mineral density to see a fracture. And that's exactly what we see. The worse your bone mineral density is, the greater the fracture risk, as you can see in the bars and blues. So if you look at an osteoporosis bone density of -3.5, you can see that there are quite a number of fractures that happen during that period of time, as opposed to if you've got a normal bone mineral density at greater than 1. But there's more to the story here. If you look at the actual number of fractures, you can see that almost 2/3 or more of fractures, as presented in this graph in the yellow, happen before the true diagnosis of the -2.5 that we call osteoporosis. So there's something about bone quality that a bone mineral density may not capture, because the actual number of fractures are far greater in a so-called normal or moderate risk bone density than when you have a bone mineral density where we call it -2.5. Bone mineral density is not the sole predictor of fracture risk. And while many people will ask for a bone mineral density, in fact, 60% of women with fractures do not have osteoporosis on their bone mineral density, as defined by a T-score of more than -2.5. Think about that for a moment. So there's something about the quality of a bone that a bone mineral density may not capture. And those are things that we can find out as we ask you questions about your life, your lifestyle, your family history. So where do women over the age of 50 fracture? And does it change as they get older? And the answer is yes. Early on, we see fractures in the vertebrae and the wrist. We see about 7% of fractures in the pelvis. About 15% of fractures happen in the hip, and typically they happen in an older age group. And then there's a bunch of other sites that include the tibia, the fibia, those are the long bones in the lower part of your leg, the femur, that's your thigh bone, the humerus, that's your arm bone, hands, fingers, clavicle. So there are other sites when we say other at 29%, those are the ones that are grouped all together. But more than 50% of the fractures that we see happen at the spine, the wrist, or the hip, and they are associated with significant morbidity and significant impact on quality of life and the ability to live an independent, active life. So I told you that 1 in 3 women will suffer from an osteoporotic fracture during their lifetime. So patients who tell me after the age of 50 that they slipped on the ice and they broke their wrist and I too would have fractured if I slipped on the ice, the answer is no, because falling from that type of height and fracturing tells you something about the bone quality. It is not a normal event. Over 80% of the fractures we see in Canada after age 50 are in fact related to poor bone quality or osteoporosis. And osteoporotic fractures in women over the age of 50, well, look at these numbers. Almost 1 in 4 women over 50 experience a wrist fracture. And a wrist fracture can make it very difficult to get dressed, to brush your hair, brush your teeth. 27% will experience a fracture in their back or thoracic spine called a vertebral fracture. 15% experience a hip fracture. And for many of those individuals, their lives will never be the same. 7% experience that pelvic fracture. And about 30% or less have fractures occurring in all those different sites that I mentioned previously. Almost 50% of fractures that occur at the spine or the hip are associated with significant morbidity and mortality, meaning death. So clearly it's not the vertebral fracture that's killing you, but it's a marker for frailty and a marker for risk of death. What about men in osteoporosis? Well, it happens a little less frequently in men, but not as less frequently as one would think. It's about 1 in 5. We used to say 1 in 8, but now it's 1 in 5. And about 25% of all the hip fractures we see occur in men. The lifetime risk of experiencing an osteoporotic fracture in a man over the age of 50 is 30%. And that's similar to the lifetime risk of developing prostate cancer. Many men will ask about prostate doing a blood test called a PSA, but many are unaware that they should be talking about their bones. Men have the same risk factors for fracture as women. And in fact, by age 65, men catch up to women and lose bone mass at the same rate as their female counterparts. Unfortunately, it's estimated that by 2025, the total number of hip fractures in men will be similar to the current number reported in women. And here's a startling and worrisome fact. Men who fracture a hip have a greater risk of dying, and they have more common other diseases despite their younger age at the time of fracture. So while less men may fracture, the likelihood of dying if you're a male with a fracture is even greater than the 1 in 4 that we cite for women in the calendar year following that fracture. Fracture risk increases with a parental history of fracture. That's both your mother or your father. If they've had a hip fracture, that's particularly worrisome. If you use steroid medication for more than 3 months because of another illness, and other inflammatory diseases such as rheumatoid arthritis or inflammatory bowel disease, these are so-called secondary causes of osteoporosis. In other words, the primary illness increases the risk of having osteoporosis as well. So the takeaway message here for you as men is that you have a higher rate of fracture-related mortality. And that means that while you're less likely to fracture than your female counterpart, you are far more likely to die within the following year following that fractured hip. So what is a so-called fragility fracture? What does that mean? Well, a fragility fracture is when you fall from what we consider a minor trauma and you break a bone. So falling from a standing height, like on the ice, that is considered a fragility fracture. There's something fragile about your bones that when you fall from that standing height that you break, that is not normal. If you fall from a sitting position or fall from a lying position, like on a reclining deck chair or a bed, or if you miss a couple of steps and trip on a staircase and fall and break your bone, or after moving outside of the typical plane of motion or coughing, these are all worrisome and they tell us there is something fragile about your bones that have led you to fracture. So who should get a bone mineral density? Well, my patients, it should not be the worried well. So firstly, everybody, meaning male and female both, 65 years and greater should have a screening baseline bone density. If you're between the ages of 50 to 64, you should only have a bone mineral density if you can identify 1 or more risk factors for fracture. So in other words, you have had one of those fragility fractures after age 40, or you have a mother or a father who had a fracture of their hip, or somebody is aware that you have a vertebral fracture because they've done an x-ray of your back or your chest for another reason and have incidentally found on the x-ray that you have a compression fracture that we can see. Medications that have a high risk of bone loss, we've mentioned cortisone or steroids, but there's a whole bunch of other medications, and I'm going to show you what those are shortly. If you're a smoker, or if you drink alcohol at more than 3 units per day. Other disorders that we know are associated with osteoporosis, such as rheumatoid arthritis or inflammatory bowel disease. Or if you have very low weight or major weight loss, that too can be an additional risk factor where we may consider doing a baseline bone mineral density under the age of 64. For those under the age of 50, these are patients who are definitely at high risk because of other underlying illnesses. They're not the majority of the people that we see, and these people are generally people that are aware because they have secondary causes of osteoporosis, such as things like malabsorption or a prior fragility fracture. Now, one of the things that I often tell my residents and my students is that if you're ordering an x-ray for an unrelated reason, for example, a patient where you're concerned about pneumonia, I always add rule out vertebral fracture, because we can look at your bones, but if we're focusing on whether or not you might have a pneumonia, in fact, we may miss noting that, in fact, you have a quiet vertebral fracture that's sitting there that nobody is aware of. We also know that if you've got concurrent illnesses, that's what the word comorbidity means, meaning some other illness along, it will contribute to fracture risk. A study done called the GLOW study was the longitudinal study of osteoporosis in women. It simply means that it followed women over a long period of time. And what we found was that there were a number of illnesses that were concurrent that contributed to fracture prediction. That included things like Parkinson's disease, multiple sclerosis, COPD or chronic obstructive lung disease, osteoarthritis, heart disease. If you have what's called an increasing comorbidity index, meaning one or more comorbidities, that multiplies your risk of fracture. These are not independent events. We think of a person as being holistic, and many of these underlying so-called morbidities or illnesses will multiply your risk for a fracture. Now, what about men? Well, the Mr. OS study, which was the osteoporotic fracture in men study, also found out that use of a tricyclic antidepressant, a particular type of antidepressant, heart disease, having had a heart attack or angina, having an overactive thyroid, and Parkinson's disease as well, were some of the increasing number of risk factors associated with increasing fracture risk in men. Now, look at this list of medication. These are medications that are also thought to be related to increasing bone loss. Some of these medications are medications that we can't necessarily get off of, but you should be aware that that may increase your risk for bone loss and subsequent fracture. So, androgen deprivation therapy, that's medication that we use typically in men with prostate cancer. Anticonvulsants, so seizure medications. Antipsychotic drugs for mental health illness. Antiretroviral drugs for our HIV patients. Aromatase inhibitors, a very common class of medication that we use for women with estrogen-positive breast cancer. Any type of chemotherapy or a transplant drug. Furosemide, which is a common water pill that's used in congestive heart failure. Steroids, prednisone, the class of medication is called glucocorticoids. Heparin long-term. Certain hormone or endocrine therapies. A medication called methotrexate that we often use in many forms of arthritis. Proton pump inhibitors, a class of medication that's used for hyperacidity. Many of these medications are available over the counter, and your physician may not even be aware that you're on a proton pump inhibitor, or you may not be aware that the medication that you're taking for your heartburn is a so-called proton pump inhibitor that may be increasing your risk for fracture. That's why it's so important to take all medications, including over-the-counter medications, with you when you see your healthcare provider to look at the impact that it may have on other parts of your body. Selective serotonin reuptake inhibitors, SSRIs, in other words, a newer class of antidepressants. And I'm not telling you to stop them if you need them, but to be aware that this is a multiplier for perhaps impacting on your bones. And excessive thyroid, not those people who are on thyroid medication to control being underactive, but those who have excess thyroid because of hyperthyroidism, or those who are over-medicated and are not in an appropriate range for their thyroid levels. These are just some of the few that may cause or accelerate your rate of bone loss. There's other factors that contribute to the long-term fracture risk. So what are some of these? A prior fracture. Now, this is something that is what we call non-modifiable. So if you've had a prior fracture, it's your reality. We can't make it go away. But recent fracture or any history of fracture is something that you need to light up, because that means it increases your risk for future fracture. Your age, as you get older, female more than male, Asian or white ethnicity, a family history of hip fracture or osteoporosis, a small frame, those comorbid conditions that I mentioned before. These again are non-modifiable risk factors, meaning you can't modify them necessarily, but you should know about them because they may increase your risk. And here's a whole list of other what we call modifiable things you can do something about. If your body mass index is too low, if you don't have enough calcium in your diet, or you aren't taking a vitamin D supplement, if you are postmenopausal with an estrogen deficiency, that too can increase bone loss. If you don't have enough physical activity, excessive alcohol intake, if you're a smoker, if you're someone who tends to fall, that's a concern. And the use of those medications that I mentioned previously, these are things that we can potentially modify and improve to decrease your long-term fracture risk. So I keep telling you that if you've had a fracture, it's a predictor for future fracture. Why do I say that? Well, these are individuals who have had a fracture. And if you follow them over time, on the bottom you can see 1, 2, 3, 4, and 5 years of follow-up. You can see that as you go along from that first fracture event that happened at time 0, your risk for fracture over the next 5 years continues to increase unless you intervene. The actual cumulative risk is about almost 1 in 3 will refracture over the next 5 years. So we don't want to ignore that first fracture. It's a call for action that has us calling out to you and you calling out to your healthcare provider, what can I do to reduce the imminent risk of a second fracture? Now let's look at this graph. It seems a little complicated, but let me walk you through it. On the bottom, you see 60, 70, 80, and 90. So these are decades. So 60 through 70, 70 through 80, 80 through 90, 90 and onwards. And what we're looking at in the 3 different bars is what happens at 6 months, what happens at 24 months, and what happens at 60 months or 5 years. And what we see is that age is a multiplier for another risk of a fracture. If you've had a fracture, that puts you at greater risk for another fracture. And as you get older, you can see over the age of 65, the very high rates that happen in the next 6 months, 24 months, or 60 months in terms of predicting another fracture. So if you're over the age of 50, 65, if you have a low bone mineral density, or you have fall risk factors, that increases the likelihood that you will re-fracture again after having a recent or prior fracture. So you have to ask yourself, since age 50, have I broken any bones? The answer is simply yes or no, and if you're a yes, that tells you that you are at imminent risk of having another fracture unless you intervene. What about the likelihood of a secondary fracture in the next 2 years? Never mind 5 years, but 2 years. And you can see on the bottom graph, we're looking at fractures at the spine, fractures at the pelvis, the shoulder bone clavicle, humerus, upper arm, hip, femur, your thigh bone, radius and ulna, those are your forearm bones, tibia and fibula, those are your lower leg bones in the ankle. And you, again, looking at it by age, 65 is the dark brown, the darker blue is 75 to 84, and the lighter blue is over 85. And what you can see is you're looking at the number of individuals who have a second fracture after having had a fracture within the 2 previous years. So what we see is that if you've had a fracture, almost 20% will fracture within 2 years following the initial fracture. And go to the 1, 2, 3, 4, 5th bar, hip, look at hip. You can see that following a previous fracture, as many as 5% will have a hip fracture within the next 2 years. And that's a game changer, because for many individuals with a hip fracture, they never will go home to live independently again. This is the 5-year data. And as you go at 5 years, look at what happens. There's now a 10% likelihood that you will have a hip fracture within 5 years after having a previous fracture. And within 5 years, there's a 30% chance that you will fracture something else. So the first fracture predicts a second fracture, and the further along we go, almost 1 in 10 will have a hip fracture. And that will be because we did not recognize the importance of that first fracture as a real red flag telling you you need to do something to prevent a second fracture. So why do we care about this? So I had a fracture, what does it mean? Well, the risk, if you're a woman over the age of 50, is more than 1 in 10 of having a hip fracture, 12% or greater. Now what happens to these women? Well, in fact, if you look at these women and you ask them, 40% of them have had a prior fracture. So they had that prior event, but somehow it didn't get treated or went unnoticed. Another 40% will need assistance walking. They will never have the independence that they did before. And startling, almost 1 in 5 will enter long-term care. And even more heartbreaking, 1 in 4 will die within 1 year. This is something that we need to prevent. This is not a normal rite of passage and a normal part of aging. It is anything but a normal part of aging. 40% had a prior fracture, didn't do anything. 40% needed assistance walking in the future. 18% enter long-term care. 23% die within 1 year. I certainly don't want that to be me or my mother. Now, what happens at the various sites? Well, depending on where you fracture, you can see that if you've had a fracture at the hip, the vertebrae, meaning your back, your pelvis, your humerus, your wrist, those are all the things that we've just talked about. Admission to long-term care, having chronic pain and resultant depression and complications, not being able to be social and having activities of daily living, the reduction in quality of life, the worry about future falls or ending up not being able to live independently, and being a burden on patients and caregivers, including lost work days and wages. It has a ripple effect. It doesn't only affect you, it may affect someone that you care for. And none of us want to be any of these people in this cartoon that's in front of you. Well, why, if you are a patient, meaning you don't have a diagnosis of osteoporosis, but we can see that you are beginning to have bone loss, would you want to be considered to be treated? Well, one is, if you've had a vertebral fracture that you're unaware of, or we see a risk factor in a patient over age 65, that's that first fracture. You don't want to have the second fracture. It doesn't really matter what that bone mineral density looks like. The fracture is what is the predictor of future risk. If on a bone density, we see that the bone loss in your lumbar spine is very much greater than in your hip, that for us as practicing clinicians tells us that that's a red flag for future risk. May not mean anything to you, but it's something that your clinician knows about. And then if you have other disorders or medications that we've mentioned about before, such as rheumatoid arthritis, the aromatase inhibitor therapy in women with breast cancer, hyperthyroidism that's gone untreated, these are some of the things that we worry about. But here's another one that people ignore. If you've had more than 2 falls in the past year, that's a great predictor for risk of fracture, because if you fall, that's a good setup to break a bone. And your own preference to be treated, understanding what that first fracture can mean, being able to say that, no, if I'm at risk for fracture, I don't want to have that first fracture because I know it may signal a cascade of events that I don't want to see happen to me. Now, how do we weigh the benefits of treatment versus the risk? Because headline news is headline news. People often hear about something called osteonecrosis of the jaw. Sounds terrible, doesn't it? But in fact, that is quite rare. And usually we see it in people who have advanced dental decay who are at risk. Excuse me. Something called an atypical fracture. That's a fracture of the upper thigh bone. Also very rare. We often see it in patients who are on a particular type of medication after 8 years of use. Again, very rare, versus the likelihood of sustaining a fracture and ending up with that 1 in 4 chance of being dead in the calendar year. The benefit of fracture risk reduction is to reduce vertebral fractures by as high as 70%, to maintain that independent living, to decrease the likelihood of illness or death, and also to decrease healthcare costs, because acute healthcare costs associated with fracture are over $1.5 billion. So I do love the media. As you know, I'm in the media, but sometimes the media has headline news that keeps us from reading. So fearing rare side effects, millions take their chances with osteoporosis. That's not a chance that I'm telling you to take. These side effects are often so rare that the benefit of the treatment is well outweighed by the potential low risk that's pretty rare. So breast cancer and aromatase inhibitors, I've mentioned that, right? That aromatase inhibitors are drugs that are very important in women who have estrogen receptor positive breast cancer, and it keeps them from having recurrence of their disease. So this is a very important drug. But it turns out that this drug is quite bone unfriendly and promotes bone loss and osteoporosis. But for many of these women, this is a medication that they must be on. Well, this is me. This is several years ago when I was diagnosed with breast cancer, and I was put on an aromatase inhibitor. And as I was focusing on my breast cancer and reducing the risk of recurrence, no one talked to me about the fact that the medication that I was taking was very bone unfriendly. And while I needed the medication, and there was no question I was going to take the medication, what could we do to protect my bones? And it really wasn't until I recognized that I'd been on the medication for a while and no one had suggested that I do a bone density that I became my own advocate and said, hey, what about my bone density? At which point I met the criteria for osteoporosis and quickly went on treatment to mitigate against the risks of being on a medication that I knew was bone unfriendly, but I definitely had to be on. So what should you know yourself? Well, ask yourself, have I broken any bones? A simple yes or no. Don't say it was icy and I fell and I broke and you too would have frozen. No. Have you broken any bones? Yes or no. Have you fallen? Have you had prolonged and unusual back pain? Because that may signal that you have a vertebral fracture. Are you on medications that can impact your bones? And again, I'm not telling you to get off these medications, but to know that this may be a multiplier where you need to be more aggressive about bone protection. Do you have that sway back? We call it kyphosis. Now, that's telling us something about the curvature of your spine that may be related to osteoporosis. And there's a test called get up and go. So if you're sitting in a chair that doesn't have arms, you should be able to get up and go. But if you have trouble getting up and go and you feel unstable, that tells you that you may be at risk for falls. And that's a red flag that you may fracture. Have you lost height? So do your pants suddenly feel like they're getting longer? When you stand against the wall, is your head right against the wall or is your back against the wall, but your head can't get against the wall? And if you put your hand under your lowest rib margin to the top of your pelvis, you should be able to put a full hand between the bottom of the rib to the top of the pelvis. And if not, that may be telling you that there are fractures in your vertebrae that you're unaware of. So there is a treatment gap, and I've pointed out to you that it's worrisome. In review of the gap associated with case finding and management of individuals at high risk for fracture, there are 4 opportunities for clinicians firstly to focus on, making sure that that second fracture doesn't happen. Remember, a fracture begets a fracture. Primary fracture prevention, in other words, cost effectiveness and prevention of that first fracture, because we know that so many after the age of 50 will have a fragility fracture. So are you talking about what we call bone hygiene? Do you have adequate calcium? Do you have adequate vitamin D? Are you doing exercises to maintain your muscle mass and to maintain bone strength? Are you taking calcium throughout the generation? I often say that osteoporosis is a disease that starts in our primary pediatric years based on the intake of our calcium and vitamin D. We wouldn't not give calcium and vitamin D to our children, but as adolescents and young adults and older individuals, we often forget the role of getting calcium and vitamin D through our diet and vitamin D through a supplementation. Osteoporosis induced by medicines. Are there medicines that a patient is on that we should be focusing on? Not necessarily because we can take them off, but because we have to be more mindful of their bone health and other diseases that we've mentioned that are associated with osteoporosis. There's lots of opportunities for us to find these people, case finding and management of individuals at high risk for fracture. So someone who prevents with the fracture already, or someone who has a disease that we know increases risk of fracture. You as a public being aware that osteoporosis matters, and if you've had a fragility fracture, to flag that to your healthcare provider and say, what does this mean for me and my future? And understanding what's happening for fractures in the developing world. They're increasing. Here's our global call to action. A lot of bone societies, so the American Society for Bone and Research in 2016 had a call to action internationally called the crisis in the treatment of osteoporosis, that the 30-year decline in hip fractures has plateaued and our population is aging. We've become too complacent. That post-hip fracture mortalities are up to 24% in women and 37% in men. And less than half of those who broke a bone were referred for a bone density test or prescribed medication to treat their osteoporosis. And the cause of this crisis, a decline in testing, diagnosis, and treatment of high-risk patients. It's important for us to recognize these patients, recognize fracture, recognize disability and loss of independence. So I want you to be your own advocate. I want you to become bone aware and look at your own personal risk factors as to what this means for you as an individual. And we've got lots of time now where we can take some of your questions and see if there's further information that you're missing. So we're just lining up some of those questions. Wow, we've got lots of them. Okay. So I can just click on them?
No, just take a look. You can see them. Oh, yeah.
But I have to double click on some of them to see what they are. Okay, does weight training and resistance band exercise actually reverse osteoporosis or stop the progress? So the most important thing about weight training and resistance is to make sure that you're building up your muscle mass so there's a decreased risk for fall. So while I can't tell you that it's going to reverse osteoporosis, it certainly will decrease your risk for fracture. It will make you a stronger individual. And this is very important, particularly not only as we get older, it's never too late to be doing exercises, but even from early adolescence. Does brisk walking improve bone density? Well, as long as you're able to briskly walk without falling, aerobic activity is important for your heart and it's important for muscle mass, but it won't necessarily improve the bone density. And it's not the be all and the end all of bone density, it's decreasing your risk for fracture that we care about more than anything else. How does your doctor decide on the length of time someone has to be on bone medication? So that's a very individualized question. For people who are high risk, it likely will be for life. You wouldn't treat high blood pressure for a while and then stop it, or a high risk cardiac patient with cholesterol medication and then stop it. But what may happen is that we sequentially change the different types of medications because we know certain medications should not be used more than 8 to 10 years. So it really is going to depend on the individual scenario, whether you're high risk or moderate risk, and that's really going to be on a case-by-case basis, and that is how your healthcare provider decides this. Here's a patient who's on a drug called Forteo. Forteo is a bone builder. It's a drug that we simply use for 18 months and typically don't use it again. You are unable to tolerate other options. So there are other medications that are on the market. Someone is asking me specifically about a new medication called romosozumab or Avidity that's been released in Canada. So I can't give you specific advice as to what medication that you should be on, other than to tell you that we have a lot of different options now in Canada, and we're beginning to understand the importance of using some medications for very high-risk patients, like Forteo over a given period of time, or romosozumab called Avidity over a period of time, and then followed by another medication. So it really is going to be case-by-case dependent. The elderly population of chronic obstructive lung disease, are they at higher risk than most other categories of health issue because of the exposure to steroids such as prednisone? Well, that's a very good question. Certainly exposure to steroids such as prednisone increases your risk, but it seems that the illness itself can increase the risk. And while we don't necessarily understand all the mechanisms, it does flag that this patient is a patient at higher risk for morbidity. It may be because of the prednisone, it may be because of the primary disease, but it means that you should be bone aware, make sure that you're having the appropriate bone density testing and talking to your healthcare provider about what you specifically can do. Does estrogen and testosterone hormones increase the risk of bone loss? Well, testosterone is off-label in women, so I won't be talking about that. But in fact, estrogen does exactly the opposite. It doesn't increase the risk of bone loss. Estrogen is bone protective. In fact, for women who are on hormone therapy because of intractable hot flashes and night sweats, we know that they will have the added benefit of protecting bones. In fact, hormone therapy is one of the medications that we can use to prevent and treat osteoporosis. Please identify recent media concerns for taking too much vitamin D. I think really what you're asking me may be too much calcium. It's very hard to take a lot of vitamin D. You have to be taking a lot of vitamin D to get vitamin D toxic. And I will tell you that we normally recommend about 1,000 to 2,000 international units. One of the things that you need to know is that vitamin D is fat soluble. So if you're taking a vitamin D pill on an empty stomach, you in fact may not be absorbing it. So we often talk about taking vitamin D as a sublingual drop under the tongue, or if you're taking vitamin D, make sure you're taking it with a meal that has a little bit of fat in it because it is fat soluble. You really have to be taking an excess of 10,000 international units or so to put yourself at vitamin toxicity. But again, it's on a case-by-case basis, and I would encourage you to talk to your own healthcare practitioner about how much vitamin D you should be taking. It's going to depend whether or not you're getting vitamin D from your diet, for example, and vitamin D fortified dairy. For calcium, we talk about having the total adult intake as being 1,200 milligrams of calcium. We prefer that that comes from your diet. So for most individuals in Canada, we're getting at least 500 milligrams of calcium from our diet. If you have dairy in your diet, you may not need a supplement at all. There was some concern that if you over-supplemented with calcium, it could contribute to stone formation or cardiovascular calcification. Bottom line I tell my patients is take a survey of your diet. It's not hard to figure out how much calcium. There's lots of lists, including on the Osteoporosis website, about which foods have how much calcium, and figure out how much calcium you're getting in your diet and how much you might need to supplement. You might not need to supplement at all. So can I explain a T-score? Well, the T-score is something that we get from a bone mineral density, and it tells us the score based on a normal, age-appropriate individual and whether your bone density that we're seeing is too little or too much. But bear in mind, you could have an increased risk for fracture and have a normal-looking T-spine bone density because you have arthritis with arthritic changes. And when the bone mineral density machine measures the bone that has a lot of arthritis, it may give you a high T-score, but it doesn't mean that your bones are not at risk. And that's why we talk about the fact that this is one tool, but not the only tool. It really is looking at you as an individual, getting your history, knowing your medications that are at risk. We really have to do this on a case-by-case individual basis, and we don't make the decision based on a T-score alone. In other words, I've seen patients who have fractured with a normal T-score, and clearly there's something about the bone quality that has had them fracture. And regardless of what the T-score says, we know that they need intervention. Is the evidence of some intervention medications more effective than others? Well, it really depends in terms of how we're treating. There are different classes of medications that are bone resorbers, anti-resorbers, and that includes a group of medication called bisphosphonates, a group of medication called monoclonal antibody or denosumab, which is a subcutaneous injection every 6 months. You're really going to have that conversation with your own healthcare provider as to how long to be treated, what to be treated with, and what the best route of delivery of your medication is. So there is no one best bone density medication. In fact, you may be on more than one bone medication over the course of your treatment, depending if you're high risk or moderate risk. So everybody's going to be individualized here in terms of how they're treated, and I really can't answer that specific question for you. So there is not one bone density medication that is best. It may be that depending on your ability to tolerate a medication, whether or not you're better off with a subcutaneous injection, it's really going to be on a case-by-case basis. And thankfully, in North America, we have a number of medications that are available to treat bone density and risk for fracture. And as I mentioned, you may be on sequential medications over a different period of time, depending on what your particular situation is. So there is not one bone density medication that is best. It's going to be variable. So I think that the message that I'm trying to give you is to be your own advocate, know what your own risk factors are for fracture. Have you attained your peak bone mass? Are you someone who didn't take calcium when you were a kid and a young adult? Do you have a reason to do a bone mineral density before age 65 if we've identified some of those risk factors that we've talked about? And for men and women both who have not had a bone density, 65 is that entrance age where everybody should have at least one baseline bone mineral density. And that bone mineral density cannot be interpreted on its own. It has to be interpreted with you as an individual. Are you a smoker? Do you drink too much? Have you lost body mass? Is your weight too low? Are you on other medications? So it's many factors that we consider when we assess your risk for fracture. But the one thing that you know is whether or not you've had a fracture after age 50. And if so, that's something that you need to flag both for yourself and your healthcare provider to decrease that risk for a second fracture, because as we pointed out, fracture begets fracture.
It's wonderful. On behalf of Osteoporosis Canada, I'd like to thank Dr. Shapiro today for her fantastic presentation and her willingness to answer so many questions. There were certainly many that came through, and we thank you all for submitting them, and thank you very much for
It was an honor to be here.
We have no doubt that her willingness to share her experience and expertise will help you on your own journey with osteoporosis. Let us know what you thought of the presentation by filling out the evaluation survey. You can access the survey via the link that will be sent to you in a post-presentation email or via the Osteoporosis Canada website. It is only through your feedback that we can deliver this type of programming to you. How can you find out about more Bone Matters presentations? Notices will be published on the Osteoporosis Canada website, news and events, and through our social media feeds on Facebook and Twitter. Better yet, sign up for COPEN, the Canadian Osteoporosis Patient Network. All COPEN members are alerted to all future Bone Matter presentations. If you're not already a member of COPEN, feel free to sign up for a free membership at osteoporosis.ca. And again, thank you all for joining us today.